Ecancer Medical Science is very keen to publish reports of important consensus meetings on any topic in oncology. They're very popular with readers, as been evidenced by our extremely fast report on the Gallen consensus meeting on breast cancer, acknowledged as the world meeting that sets the rules for the next year or the next 2 years. Giuseppe Curilano wrote a very rapid meeting report for ecancer, and this has already been seen 6,000 times by people from all over the world. A more boutique conference has been reported on a slightly more specialized area than breast cancer, namely germ cell tumours in the central nervous system. Nevertheless, about 100 people attended the recent meeting, and it's been reported to ecancer by Steve Lowes from Bristol and his colleagues from Cambridge in the United Kingdom. There were one or two areas of dissension, and one of them was the role of surgery. The other main one, which needs to be worked on more, is the classification of these central nervous cell tumours. But there was real consensus, and this is important for you doctors watching this programme, to read about the areas of consensus. In short, they were that first-line treatment for any part of the CNS with a malignant germ cell tumour was radiotherapy. So radiotherapy is first-line treatment. For the non-germinomatous germ cell tumours, malignant ones, it was agreed, consensus again, chemotherapy added to the radiotherapy. When radiotherapy is localized, it was also agreed for malignant germ cell tumours to add chemotherapy. So those were the major areas of consensus. The areas for further development and further discussion include the further search for biomarkers which would help to monitor patients as they're going through treatment, look for early relapse, etc. Also, perhaps, as has been the case in leukemias and myelomas, biomarkers which might end up as targets for development of new drugs. There needs to be collaboration across the world on this, and there was agreement that this would continue after this conference. The big focus of the meeting, on which there was great consensus, was how to minimize the late effects of radiotherapy and chemotherapy, because don't forget that these germ cell tumours are commonest in young people. And then a question to be answered in the next couple of years was definitely the role of proton therapy in the treatment of these tumours. One of the articles which I've chosen for this month. It's an interesting case report, and it comes from Dr. Sharma and Mujja from New York University in New York. And they observed an extraordinary combination of side effects from a drug called leuprolide. The patient was 40 years old, she was a lawyer, she had a small breast cancer, and after treatment of the local tumour, she was put onto tamoxifen and leuprolide in order to suppress her ovaries. Then an extraordinary thing happened. She developed supraventricular tachycardia. Now, immediately one thinks of leuprolide because there's a case reports of leuprolide in men with prostate cancer, usually over 60. But even then, it's not a particularly common problem, but it was assumed it would be related to older age and men. But here we have a case of a young woman with breast cancer who got supraventricular tachycardias. And then, just to make things worse, she got urticaria, quite marked urticaria, every time she got a supraventricular tachycardia. When the leuprolide was switched for goserelin, the whole problem disappeared. No more tachycardia, no more urticaria. She continued on goserelin and tamoxifen for a couple of years, and then has been off for a couple of years without any problems, and is wanting to start a family. Her ovarian function has returned to normal. The issue, of course, is it leuprolide that is causing the urticaria? and why should it be associated with the supraventricular tachycardia. It's a possibility that the way that the leuprolide is formulated might be an issue, but formulations don't usually cause supraventricular tachycardia. However, it's worthwhile bearing in mind that even in young people, a side effect of leuprolide can be supraventricular tachycardia, and look out for urticaria. A case report has caught my eye, and one of my editor's choice discussions, because it addresses a really quite perplexing problem, namely the follow-up of a young woman with breast cancer treated with local surgery, radiation therapy and chemotherapy, and followed up by the use of markers, CEA and carcinoma 15.3, and what to do when these markers rise. Not much point in doing them if you don't take action, and the question is, where do you start looking for suspected relapses in the form of metastasis? Interesting case report from my own institute in Milan with Gilardi and co-authors described such a case, a 35-year-old woman whose CEA and CA 15.3 went up, and there was no sign of where there might be metastasis, no palpable metastasis, and the usual radiological tests showed nothing. However, an fluoro 18 FDG PET CT immediately showed up the issue. There were small liver metastases which had not been picked up by other tests, but what was most important for the management of the 35-year-old lady was the fact that there were 2 intramedullary metastases, that is inside the spinal cord, which will, in their natural history, progress very fast, usually within a month, to pressure on the spinal cord and subsequent paraplegia. Interestingly, there was the 3rd intramedullary metastasis, which the FDG PET scan didn't pick up, but it was picked up with more scrutiny of that area with a magnetic resonance image. So if you're perplexed about where the CEA and other markers could be coming from in a patient who is otherwise doing well, treated successfully, in inverted commas, then this group at the IU in Milan are recommending a fluoro 18 FDG PET CT scan.